Professor, what do you feel is the optimal wearing time for the reverse pull headgear?
It depends of the patient, of its age. If the patient is young, that is to say about 6, 7, 8 years, it is usually sufficient to put the tractions during 6 months. If the patient is about 9, 10, 11, 12 years, it is generally more difficult, and the time must be sometimes 1 year. But to stop, we must absolutely sure that the skeletal correction has been obtained. For that, I believe that it is indispensable to have a good teleradiography and a good logiciel for examine, for precise if the axe of the maxilla and the position of the symphysis are aligned. Then the duration of the traction depends on the quality of the result after 6 and sometimes 1 year of treatment.
Professor, how many hours a day do you feel the patient should wear the reverse pull headgear?
In the first years, we put the tractions during about 70 hours by day. But progressively we reduce, and now I think that the traction must be put only the night. Maybe sometimes, but I believe it's not absolutely indispensable for 1 or 2 hours before the night.
So, Professor, from what I understand you've said, you feel that the reverse pull headgear traction should be started as early as you can diagnose the maxillary deficiency.
Yes, I totally agree. It is contraindicated to treat in first time by other appliance that mass, that traction. And after the traction, often it is too late. When you have really a retrusion of the maxilla, you must put early your traction, and after, eventually, use another appliance to obtain a good result at the level of the teeth.
So, Professor, in your sequence of therapy, do you like to develop the maxilla at the same time you're bringing the maxilla forward with the reverse pull traction?
Yes, indeed. Often, maybe always. In class 3, the maxilla is narrow, and the patient breathes by the mouth. Then it is very important to expand the maxilla at the same time, or just before, to exert traction. Yes, I believe that it is important to associate the two therapeutic actions.
Professor, do you feel that the maxilla can be retrognathic relative to the anterior cranial base, even in a skeletal class 2 condition?
Yes, I believe that. It is a very interesting and important question. Because when a class 2 is corrected, occlusion by inocclusion, but that the maxilla stay retrognatic, it is a condition which can be responsible in the future for sleep apnea. The tongue has not the possibility to dispose into the buccal cavity, oral cavity. Then I believe that it is very important to diagnose in class 2 or in class 3 retrognatic maxilla and to treat.
As a final question, Professor, how do you actually measure the relationship of the maxilla relative to the anterior cranial base?
Please, Chris, would you translate my answer? J'ai mis au point une...
To assess results, I've been led to alter the use of the endpoint, which is variable. I have devised an analysis which enables me to assess results with a vertical line drawn down from the vertical maxillary process down into a symphysis when the results are good. This, of course, in the Bimble analysis corresponds to factor 1.
Thank you, Professor, for joining us today on Meet the Clinician. We truly appreciate you sharing your years of clinical experience and research with us.
Thank you very much.